Well, good evening, everybody. On behalf of Setting Scoliosis Straight Foundation and the Harm Study Group, we would like to welcome you to our surgeon education webinar, very appropriately named for today, Leaps in Treatment of Cerebral Palsy Scoliosis. Tonight, I am delighted to be joined by my co-moderator, Amit Jain, who has done a tremendous job of putting the faculty and the program together tonight. And I am confident at the end of this, we're all going to be left with many tips for our patients. Next slide. As you can see, we truly have an all-star lineup of our guest speakers who we will be introducing separately as we move along. Next slide. And I'll hand it over to Amit.
Thanks, Dr. Samdani. Just some housekeeping instructions. Please submit all your questions through the Zoom Q&A section, and that will be handled by the moderators. And then questions may be posed at the end of each talk for the speaker for that particular section. Next slide. So this is our agenda today. We have a really exciting lineup all the way from caregiver expectations and counseling, risk stratification, tips for managing difficult curves through ages, HRQL outcomes, changes over time and how we have gotten better. And then finally, a message from Michelle and our sponsor, Stryker. Next slide.
So as many of you may know, the Setting Scoliosis Straight Foundation is a nonprofit organization. We were established in 2018, and our mission is to better discoveries and advanced techniques in the treatment of scoliosis in children and adolescents worldwide. And our vision is to see a future where children with scoliosis have the ability to live healthy, happy, and productive lives. And we truly feel education of surgeons and of our patient population is truly essential for us to be able to accomplish both our mission and our vision.
Move on to Ed Macy here. And Ed is from Stryker, and Ed is a renowned person that all of us know and rely on, and he's very kindly sponsored this webinar. So Ed, if you can give us a little.
Thank you, Dr. Jain. It's a privilege to be here tonight on behalf of Stryker, and I don't think there's a greater opportunity for us at Stryker to live our mission than when we get the opportunity to work together with you all in the world of deformity surgery. Our efforts in deformity surgery for supporting the community come in multiple forms. Yes, we're very proud to be one of the primary sponsors of the Harm Study Group's research in the CP world, some of the research which you have reviewed here this evening, but also our involvement in some of the societies, specifically the 5, if you will, major deformity-focused societies, as well as many others across the globe that we'll be involved in this year and beyond. You saw an early picture, I think, when I first started of some of our mission work in Ghana, but please know our focus is global. We have multiple efforts all across to give back to people and communities all across the world. And then certainly a focus on education, not just education of HCPs and our over 100 medical education programs we'll be involved in, but kind of an increasing focus on patient education and specifically scoliosis awareness. Yes, there's a technological focus or a technological commitment as well. We maintain 3 families of deformity systems in our hardware portfolio. Also our AeroTrue CT, a device that allows you to scan a full meter of the spine. One scan, 43 seconds, but most important factor is an opportunity to have customized dose modulation relevant to tonight for those reduction in radiation for those smaller and pediatric patients. A brand new navigation system launched last year that we're very excited about, but most importantly for our future is building on our experience with the Mako platform, the most widely used robotic system in the musculoskeletal space, which we'll be bringing to the spine community in the upcoming months. If there's anything in the world of our commitment to deformity that's of interesting to you, you can certainly use this QR code to reach out to us. You can also email me directly. It's ed.macy, M-A-C-Y, at stryker.com. Again, it's a privilege to be involved in this with you, and we appreciate the opportunity to do so. Look forward to seeing you throughout the year.
Thank you, Ed, for all that you do and your incredible sponsorship for HSG and all the work that's done across the spinal deformity community.
So I'm going to kick it off. This man does not need an introduction. Dr. Firoz Miyanji is going to kick us off with caregiver expectations and counseling and CP scoliosis surgery. Take it away, bud.
Can you see my slides okay? Okay, so as Amr said, I've got to talk about caregiver expectation and counseling CP scoliosis in 6 minutes or less. These are my disclosures, nothing which is relevant. So when you look at the Hippocratic Oath, interestingly, patient autonomy is not even listed. However, the World Medical Association Declaration of Geneva, which is actually the oath we all took, lists autonomy, and it's the third tenet. When you look at autonomy, it's important to realize that patient autonomy really has two components. One is self-rule, and the other is informed decision. But what is being informed? The criticism is that this often is simply listing the components of surgery and making the patients decide. And this traditional model is being phased out with a call to evolve from this paternalistic Hippocratic era attitude towards more of a partnership with the patients and their families. Now, the traditional informing consenting is felt to be very, again, unidirectional. The surgeon to the patient is given information, and that's presented as evidence. However, we know that studies and evidence aren't always patient-specific. So pivoting towards discussion around the patient's treatment journey as opposed to just surgery may be a better approach. This study looked at informed consent and informed decision-making and found that, again, surgeons are really good at listing components of the surgery, but discussing the impact on daily life, patient preferences, their uncertainties, and understanding are often lacking. And it's very important in CP scoliosis surgery because a patient may have had a VDRO, and if you go ahead and fix their pelvic obliquity, you can introduce a windswept deformity to the lower extremities, and that'll have a lot of impact on their quality of life and perinatal care. Similarly, they may have had fusion down into the pelvis, and now they don't have any flexion through that lumbosacral junction, and much of the torso to the hip flexion moment will be coming from their hip. So you really have to assess that as well. Again, as a spine surgeon, unfortunately, I think our focus really is looking at a progressive, relentless curve. And if it approaches a certain magnitude, then you consider surgery. But again, this is very unidimensional because we're anatomizing the patient as opposed to really treating the condition. And then to that end, of course, we have to understand health-related quality of life, which the WHO defined in 1948 as the complete physical, mental, and social well-being state, and it's not nearly just the absence of disease or infirmity. And since then, I think it's been an increasingly important component, both in practice and research, because it offers the individual and the group their ability to let us know what they perceive of their health over time. Again, it's emphasizing what the patient or the caregiver's perception is and their perspectives on their illness and treatment. And we all know that measuring health-related quality of life involves instruments that are psychometrically sound. Again, of course, in spinal deformity, we know that in CP, there's progressive curves in GMFTS 4 to 5 in 3/4 of the patients that may affect their pain and seating difficulties. I'm not terribly convinced that cardiopulmonary and GI effects is truly associated with the curve, but there have been some reports around this. So in terms of goals for me for surgery, I really want to prevent the progression, improve sitting balance and spinal alignment, decrease pain, and hopefully improve their daily comfort and ease of care. So again, focusing on quality of life impact and improvement. And of course, this does need to be balanced with the data around the potential significant complication risk profile with these surgeries. And that's where I think health-related quality of life instruments have been important in providing both surgeons and patients information to help balance the risk-benefit or pros-cons discussion around surgery. For CP, it's important to recognize that a validated spine-specific questionnaire actually doesn't exist, but I think a good generic instrument that's available that's been used in the past is a CP child. You know, the CP child was the brainchild, or the CP child actually was the brainchild of Uni Narayan. And for the patients with CP, it's been shown to be a valid and reliable questionnaire to assess health-related quality of life. However, specific to scoliosis surgery, data around its responsiveness is lacking. And I think, looking at responsiveness, it's very important for a health-related quality of life questionnaire because it's the ability of this questionnaire to detect change over time and whether these changes are actually valid. And so through the HSG, we looked at the responsiveness of the CP child against anchor questions by collecting these on consecutive patients over time, preoperatively, 1 year and 2 year post-op. And we actually did find that certain domains of the CP child were strongly correlated with those anchor questions, specifically total scores and the anchors of quality of life, comfort, and ease of care, the quality of life domain on the CP child, and the anchor of comfort, and finally, personal care and comfort domains and the anchor ease of care. So again, the CP child did demonstrate responsiveness in both quality of life, personal care, comfort, and total score. And so we use this information and published a study looking at the risk-benefit ratio of Scoliosis surgery and CP in a cohort of 69 patients followed for 5 years. And we found significant reported improvement by the caregivers in all 4 anchors, and continued improvement in these anchors were seen between 1 to 5 years following surgery. And in terms of the CP child scores, there was improvement again in personal care, positioning, and comfort. And interestingly, despite a reported 46% complication rate, there was no effect on health-related quality of life. So I think studies like these around health-related quality of life can provide important information to help start the discussion. However, it's crucial to keep in mind that the evidence is generic and not necessarily specific to that individual patient. And today, it's not only data that we present to patients, but many come in already having done the research. And so it's equally important that we act as stewards and guide them through understanding of that data. I think aligning goals is the way forward, and evolving from the traditional informed consent to informed decision-making is the way forward. Thank you very much.
Firoz, that's a phenomenal talk. We'd like to open it up for any questions coming through the Q&A. We've got a couple of minutes for questions. So Firoz, a couple of quick questions here. Main concern of our patients and their caregivers is pain before surgery, and how is this going to respond after surgery? Can you just comment on how you counsel caregivers and patients on how their pain may be affected?
Yeah, great question, Amr. I think it's important to understand where the pain is coming from. I think in very significant curves where you have, say, rib-on pelvis deformity, if that's the source of the pain, I think by offering surgery, you can improve that specific type of pain. If it's pain elsewhere or something that's more related to the condition of cerebral palsy, but not necessarily the deformity, I think it's going to be pretty difficult to suggest that improving their alignment or their seating or their posture in terms of their torso will have any effect on, say, pain that's from the hip. I think elucidating that is really, really important, because a lot of the patients will have hip or groin pain, not necessarily related to their scoliosis. So I think it has to be really cautiously understood before surgery to then say, yeah, we can affect that particular type of pain after surgery.
Yeah, absolutely. A lot of different potential etiologies for that pain. Well, excellent talk. We will go ahead and go to our next speaker. Please, really asking all of our participants, put your questions into the chat box. One of us will do our best to get back to it. I have the pleasure of introducing my partner, Dr. Stephen Hwang, on perioperative risk stratification and optimization. Go ahead, bud.
Thanks, Amr. So I'm going to start broader with neuromuscular and hone in a little bit on periop issues. Obviously, no disclosure is relevant to this, but periop, I thought to include pre-op, intra-op, and a little post. So we'll try to compress this and focus on some of the big issues. This is an example of a 14 hypoxic injury encephalopathic kid, basically that I treated a couple of years ago, and there's a stiff curve. Ended up doing traction L1 VCR and got a CSF leak, infection, long hospital stay, so many complications. So the question, what could I have done better to reduce that risk? And looking at the overall risk in CP population, we know with Brian's and prospective studies, Brian Snyder's series had about a 65% complication rate. Firoz just mentioned his 30 major complications up to 48, any kind of complications. And then we look at neuromuscular scoliosis, it's a very heterogeneous group. CP obviously is a big part of that. It's probably the most common diagnosis we see. But that diagnosis does change by the type of complications we encounter, as well as the risk of that complication. There was a early onset paper from the PSSG looking at it, showing basically a higher rate of unplanned return to the OR, likely from wound issues in myelo patients, but actually worse mortality in the CP population long term. And then our own Paul Sponseller published his own group from Hopkins looking at Rett syndrome patients compared to CP patients. And really, even though the Rett syndrome patients had lower or better GFF-CS scores, they had more pulmonary issues post-op and required more positive pressure ventilation. So the diagnosis does impact a little bit of what you're going to encounter post-op. And then there's also some studies looking at the type you have. Obviously, the kids that are more functional, mentioned CP and ambulatory, have better control. do a little bit more like AIS. So Ori had a paper in 2022, and really the ambulatory CP patients in his cohort behave more like AIS curves with lower readmission rates and lower infection, lower complication, as opposed to classic C-shape, more like the GFNSCS 4s and 5s we see. And we looked at it and presented last year, just the kids that were spastic tend to have more blood loss, more need for transfusion within the harm study group. So obviously all this ties in terms of ambulatory status. If you're going to fusion of the pelvis, you often have longer surgeries, more blood loss. And Amit and Paul published on the GFNCS subclassification, which is probably one of the most important criteria to look at pre-op. And if kids essentially have a seizure disorder or nonverbal, have a trach or a G-tube, the presence of each one increases the risk of a post-op complication. It starts around 12% and goes at almost 50%. So I think this is all very important, like Firoz talked about, to really balance the risks and benefits of surgery and have that discussion with the family as for their expectations and our own expectations, obviously. This is an example of a 15-year-old AMC child who's pretty stiff and non-functional arms and legs. And really, we did not feel we could kind of improve upon her curve with traction or with anything. The risk was a little too high. So after several discussions, we chose not to do anything. If you do decide to proceed, obviously, what else can you do pre-op? So obviously, medical consultations, look at endocrinology if they need it, pulmonary functions. Multidisciplinary conferences is something that is pretty mainstay now. And so Davisa had a paper from TCH looking at it, and they felt at the 1 year mark, they had lower mortality and neurologic deficit after implementation of a multidisciplinary conference. So really, there's probably more indications, meaning selecting who is appropriate for surgery or not, that can have a big impact on outcomes. And then halogenetic traction is very useful. We lean heavily at our institution or staging it, and then addressing any preoperative issues. And then looking at modifiable and non-modifiable risks. So BMI is a big one. There's several papers looking at larger BMI being associated with greater risk of infection, wound issues, UTI, and readmission. We also obviously worry about very, very low BMI. And we kind of address some of the consultations we want to get. In one paper, they basically found 2/3 of the kids had pre-op pneumonia. So really optimizing their pulmonary status before surgery is important. And there's even a paper looking at curve size. So basically, if the curve got to 90 degrees or larger, they tend to have a higher risk of infection, blood loss, and then the surgeon chose more anterior posterior surgery, which may relate to some of the complications. So kind of doing it a little before the curve gets too big and not unreasonable. Then intraoperatively, there's many different things that surgeons have tried, but TXA is probably the most well-established. There's many studies, prospective studies looking at it. Really, what other technique you use is more varied, but we tend to use gram-negative coverage for antibiotics as well as gram-positive, intra-wound antibiotics. And then we drew this from Pete Cable's, but inclusive dressing on the back until they have a bowel movement post-op. Rowe had a paper looking at povidone solution, and they decreased the infection rate from 14 to 7%. So it's not unreasonable to consider that. And you may want to use the true surgeon approach. Again, it varies by his institution, but there's some data suggests quicker OR time, decreased blood loss, and that might reduce some of the complications you see post-op. And then post-op, obviously, early extubation. And then, aggressive bowel regimen, antibiotics. There's a lot of less literature on this, but a lot of different techniques people try to adopt. There's one paper saying if you have greater than 50% correction, they actually decrease pulmonary issues, but this is also retrospective. Ultimately, I think implementation of protocols is probably the key. So there were guidelines that came out in 2013. Stefano published the reduction of their infections post-op after implementing these guidelines from 16 to 44%. And likely it's not necessarily which guideline you pick or which protocol, but establishing standard of care and protocols through your institution or hospital. Stop sharing.
That was outstanding, Steve. Thanks for sharing those tips. If you see a patient in the clinic who you're meeting for the first time, what are the top 3 things that you look at in terms of risk stratification?
So yeah, especially for CP, I lean heavily to your grading system. Basically, if they have a G-tube and trach, all those things. Curve size, I think for me, it changes a little bit the management. If they come with a 120-degree curve, I expect, higher morbidity associated with it. And then a little bit of flexibility of the curve from a surgical point of view. But the overall gestalt of their protoplasm is important.
Great. I see a question in the chat about ERAS protocols for neuromuscular patients. Could you talk about your institutional adoption of those protocols and how to get all the surgeons and anesthesia teams together on that?
Yeah, so I think the best thing is if you get buy-in from each department. So our anesthesiologists have been great. They actually came from DuPont. We kind of stole them from Suken, but they had their own policies, like to give basically transfusions early and platelets and things. So they basically, I think if you have their buy-in where they're actively participating and take the initiative, it helps. So if you have like somebody from anesthesia, somebody from the ICU that can really champion your efforts, I think it helps implement these policies.
Well, thank you very much. And next we have Dr. Suken Shah, who is a world expert in pediatric spinal deformities and is the chair at DuPont Children's Hospital. So I'll let Dr. Shah talk about tips for managing difficult and large curves.
Thanks very much, Amit. It's a pleasure to be here. You know, we noticed in our participants, we're over 100 participants live. Many more 100 will see this content at their own leisure. And there's 4 continents represented. So I think this is outstanding to have this much interest in such a great patient population. There are some relevant disclosures, but I'll get to the main point that what you're going to hear over this hour are all of these different things and the importance of managing such a complex patient population with a very standardized protocol and an attention to detail. The natural history is relatively unknown in some of these syndromic disorders, but I think for cerebral palsy, we know that during the adolescent growth spurts, these curves really take off. And the management of scoliosis in neuromuscular patients poses a lot of challenges. What's the approach? Do we fuse to the pelvis? What's the correction sequence? And then we have all of these other issues with poor bone density, a higher rate of infection, and a propensity to bleed. The treatment goals seem relatively straightforward: comfortable sitting, and get satisfaction and buy-in from your patient and family and caretakers. But these seem elusive for us to achieve in a standardized way. The radiographs are more than just a Cobb angle. We've got a lot of things to consider. And I like to divide this up into sagittal plane concerns and coronal plane concerns, but obviously there's definitely the third dimension. In the sagittal plane, I find kyphosis and hyperlordosis the most difficult issues to tackle. And many of these are present in the same patient in the thoracic and lumbar spine. And we know the incidence of proximal junctional kyphosis is very high if you don't get above the native kyphosis and almost into the cervicothoracic junction on many patients. This patient is a representative of this issue with hyperlordosis after a selective dorsal rhizotomy and has over 100 degrees of lordosis. After surgery, he's participating in law school, is now currently practicing as a lawyer, because for the first time after surgery, he could sit comfortably. In the coronal plane, we obviously have the large thoracolumbar scoliosis curves, which become stiff. The pelvic obliquity poses a problem for rib on pelvis impingement that for our nonverbal patients has to be painful, but we can't gauge that symptomatology. And the proximal thoracic curves are also very difficult to treat. You can see here, most of our correction sequences start from caudal to cephalad, but a stiff proximal thoracic curve is very difficult, not only to instrument, but to actually get your rods connected. And you can see that many of these are accompanied by maybe congenital elements in the syndromic population, but certainly autofusion and very stiff curves. And sometimes our standard anchors aren't able to be used, but we have to choose alternative fixation. But sitting balance is what we're trying to get after, not full curve correction. In here, this patient has both a double major curve pattern coronally, and then accompanied hyperthoracic in the thoracic spine and hyperlordotic in the lumbar spine. This is probably as complex and severe and stiff as it gets, and we know that we have some adjuncts to use. We can use reduction type implants, we can use intraoperative traction, we can use posterior column releases with pelvic fixation to get adequate sitting balance after surgery. For the more severe patients, whether you're dealing with a curve of 70 degrees versus 100 degrees, we found that the larger curves frequently required anterior surgery. Anterior surgery, with it comes increased OR time, hospital stay, ICU stay, and intubation days, and a longer hospital stay overall. However, we can get there with a similar correction and health-related quality of life. And in another study, Yaszay also showed that intraoperative traction can get you where anterior surgery can get you, and with better pelvic obliquity correction. Whether you choose to do that with a distal femoral pin, boot traction, or tape, try to level the pelvis intraoperatively and not aggravate the hyperlordosis in the lumbar spine at the same time. What's the current status of BCR? I think when there's no other solution, you should probably try it. This patient had osteoarthrosis and a very complex kyphoscoliosis at the apex with a limited instrumentation plan. The only way to achieve proper balance was a VCR in this patient. And in this patient with a very severe thoracolumbar curve and hyperlordosis, we did an apical resection anteriorly and staged that with a posterior resection. And in this article, Paul tells us that it's a complicated minefield, and I would say that the incidence of needing this operation in this population has gone down. How do you treat this curve? Well, what we go back to is our standard principles of intraoperative traction, making the curve more flexible, reduction type implants, starting from the caudad, proceeding to the cephalad, and trying to get overall spinal balance in a comfortable sitting position from this to this, and this to this. When you look at complications, it's the assessment of risk factors. If 40% of these patients are going to get a complication and most of them are pulmonary, why don't we try and prevent those by decreasing the pulmonary complications? The risk factors seem to be the sagittal plane issues of kyphosis and lordosis, staging procedures, and now since everybody uses antifibrinolytics, we have a decrease in overall blood loss, which is an independent predictor of complications. So the surgical treatment for severe curves, I like to talk about prophylactic versus reactive. Assess the patient comorbidities, and as you heard, modify that can be modified, and try to prevent the complications by going with less surgical invasiveness with a posterior only procedure. When the curve is reasonable and the patient's healthy, the outcomes are better. So we start to talk about surgery with this family even before we actually want to operate, when the curve is still flexible, to avoid having to do an anterior procedure. And then when they're ready for surgery, we can do a straightforward posterior procedure with an excellent outcome. Let's give these kids a chance at a better quality of life, which is what this is all about. So what do you want to take home? Talk surgery early. Think about this as a prophylactic procedure when the patient is healthy rather than reactive. When the patient's exhibiting symptoms from the curve, it's almost going to be a salvage situation. Engage those families' expectations of what's going to happen. Go with a posterior only procedure, intraoperative traction, reduction type implants, and posterior releases that don't bleed a lot. Go for sitting balance and avoid the complications through prevention. Thank you.
Wow, Suken, great talk. You touched on so many different great tips and pearls in there. Let's see if we can just expand on a couple of those. Suken, tell me, when do you think, what's your indication for going in the front right now? Like, how do you decide that? Is it a rigidity? Is it a magnitude? Is it looking at the child and saying, this is what I need to do to get them balanced? Like, how do you decide when should we go to the front?
Thanks, Amr. I think going to the front is probably less common than it was in the past. Maybe we're better at posterior only. Maybe the implants are better. Maybe we know we can do more. I think it's a rigidity issue, not a magnitude issue. I like to look at the patient under traction, both clinically as well as radiographically. If it's a long sweeping curve, an anterior release might be better than doing any kind of apical resection posteriorly. And then it's really about, can a patient tolerate the anterior procedure simultaneously the same day, or do you want to stage that where that becomes more of an issue? But I think it's a rigidity thing. And when you look at the mathematics of it, we found that on a stretch film, because the bending films don't do the big curves justice, but on a stretch film, if you're only getting 35% flexibility, say 100 down to only 65 or something like that, then you should probably think about an anterior release. Because when you leave a large residual curve, I feel like the complication rate is higher, both in the perioperative and then later in the postoperative period.
No, absolutely. And I think to really loosen it up coming from the front, sometimes, as you know, they're so rotated, Suken, where you can cut those discs from the back as well. So you're still coming to the front, but really through that posterior incision. So yeah. Great talk.
Thanks.
We'll move on to Dr. Yaszay, who's going to be talking to us about managing curves at different ages, juvenile through adolescence.
Great. Thanks, Amr, and glad that I'm following Suken. It's such a great talk. But I do get to learn a lot from him, so love it. So I'm going to actually be talking about the management of curves at really different ages and really looking at kind of that juvenile through adolescent population. These are my disclosures, none related to this. So I do want to start off really first with the juvenile CP scoliosis patient. And really, I think the question becomes, should this be approached through a growth-friendly instrumentation opportunity versus doing something definitive? And obviously, we're now at the point where we're moving ahead with surgery. So I think, one of the ultimate questions with regards to any of these younger patients is there an opportunity more to tweak out a little bit more extra time with conservative management? And I don't really want to address that because I think that for me, ultimately, that's probably a flexibility issue more than a magnitude, and where the patients and their families are all at with all of that. But, Paul Sponseller did a phenomenal job really telling us, and for me, this paper is critical in a lot of the decision-making that I do with regards to this population, and really analyzed what does growth-friendly instrumentation, and specifically looking at distraction-based traditional growing rods. It was a relatively, small cohort at the time that he looked at, but a very powerful message considering that 30% of them got infected. And then with using growth instrumentation, there was really no protection from crankshaft, which is ultimately, I think, one of our goals is controlling the scoliosis in a way that allows the patient to continue to grow. It had high complications and, greater than the idiopathic patients in terms of growth-friendly instrumentation. And, based on the previous talks, especially by Stephen, right, we're already talking about a population that has a high rate of complications. Now we're adding a type of instrumentation or treatment plan that also has a high complication rate and really kind of getting an additive effect, especially when it comes to the numbers of procedures that needed to be done. So we took a little bit of a different approach, and through the harm study group, we looked at a similar group of patients, but instead looked at what it looked like was just to do, an early definitive fusion. And again, a relatively small cohort, but this, we took this out to 5 years and looking at this population. And what we found in these kind of late juvenile patients that if you do an early definitive fusion, get a solid fusion, you really do both improve the deformity, including the pelvic obliquity, which then translates to improved seating, but that the CP child scores, those improve, and then they remain stable at 5 years. And for this population, right, we'd love to be able to do a one and done surgery, and there were no unplanned revisions. And so definitive fusion is a viable treatment in these skeletally mature patients, and maybe the consequences of keeping the patient small, in terms of just caregiver and how they manage those patients are actually positive effects of a early fusion. Suken took the study to the next level and took those two populations and then put them head to head. And again, comparing fusion patients to patients that were matched in terms of their growing rod treatments, and found again that early fusions or definitive fusions resulted in better correction rates. But more importantly, they had less complications and unplanned reoperations than the traditional growing rod patients. And again, if we think about this population and how many times we want to bring them to the operating room, I think we can all agree that we would like to do it once, if none at all. Does that mean that growth-friendly options are not, or that growth-friendly instrumentation is not an option for this? Unfortunately, some patients present even earlier than a late juvenile, and so I do think it is important that we know what those options do look like, and they come in two forms. And I'm going to provide a little bit of controversy in considering that fusion is also a growth-friendly option. But let's first talk about distraction type, whether it's a traditional or an MCGR. For me, I think of this more than just really in a CP population, but in a neuromuscular population, as these are good options for patients who are still somewhat ambulatory. If they're not ambulatory, I think of them as having minimal pelvic obliquity. And again, I would put this in the category as they're too early for the definitive fusion. So it's really the early juvenile that I would be considering doing this. For me, I'm looking for a long sweeping curve because I think distraction works better when there's lots of discs in between to be able to get correction than a short acute deformity. And again, looking for some moderate flexibility. So I would consider putting this in a patient that's already, that hasn't got to that stiff component yet. They need to be acceptable sagittal profile because, again, we heard that PJK is a risk factor in this patient population, but PJK is also a risk factor when we use distraction-based implants. And ideally, we're talking about patients that can't tolerate orthosis or conservative management. And for me, these are patients typically that have minimal spasticity to relative hypotonia. And so this would be an example of a patient that I would consider doing that on. I'm also going to throw out this idea that a limited anterior fusion and kind of, basing on the question that Amr had about when would you consider, an anterior procedure? For me, this patient population is actually potentially ideal. Obviously, they need to tolerate an anterior procedure. So and the younger the patient with a bigger curve, typically the more sickly the child is. So I do think it's important that that be taken into consideration. But for a non-ambulatory spastic patient where they're, too early for a definitive fusion, I think this is a really good option, because what it does, and you'll see in the next set of images, it allows for continued thoracic spinal growth. So we're looking still, again, what are we trying to maintain? It was a thoracic height. It's really probably lung function that we're looking at maintaining in this group. Again, for most caregivers, on average, I don't think they're necessarily worried about how tall their child's going to be. The other thing is this allows for basically a staged procedure for this group of patients. And so here's an example of a 6-year-old who had a relatively stiff curve and was thought to be too young and too small for an early definitive fusion, and basically had a limited anterior procedure, again, relatively extensive in the thoracolumbar portion of the spine, but the pelvic obliquity was able to be controlled. And then ultimately 5 years from the time of, essentially 7 years from that preoperative image, ended up having a definitive fusion. And so ultimately got 7 years with 2 surgery, which I don't think is easily done with any type of distraction-based implants. What about the adolescent CP? So that was the other. For me, again, I think we're not questioning what the actual indications are for surgery. I think that was done nicely by Firoz and others in the previous talk. But it relates a little bit to what Suken brought up, and it's how do we approach the adolescent CP patient? And do we have a proactive versus a reactive approach? And this was looked at and published about 5 years ago. What we did is we took a group of CP scoliosis patients in the Harm Study Group database, and we separated it out based on Cobb measurements, which, again, coronal deformity between 50, 70, 70, 90, and then greater 90. And we try to look at, what is the ideal time point. And what we found was that there was no real clear benefit or improved outcome when we were operating on patients below 70, when you compare it to the middle group for between 70 and 90. But if you waited for the deformity to greater than 90 degrees, it increased the risks of surgery, specifically when we looked at length of stay, blood loss, and other complications. And what was also important is we don't get them as straight, and we don't get these patients to have, in terms of the HQRLs, at equal improvement once they are looked at postoperatively. So, in conclusion, I would say if I look at the juvenile CP patient, my first choice is an early definitive fusion, especially for a late juvenile. My second choice for an early juvenile would be a limited anterior fusion. And then for the CP scoliosis patient, I think a proactive approach would be doing surgery before 90 degrees. Thank you.
Burt, that was an outstanding talk, and thank you for sharing those pearls. My question for you is, when is early too early? So in other words, what factor? Are you using age purely as a criteria? Are you using thoracic length as a criteria, the curve size? What is your primary decision-making point of early fusion?
I mean, I think ultimately for me in this group, treatment is determined more by flexibility and then the magnitude. I mean, we have very large curves that, frequently are flexible. And when I start to see that curve getting stiff, that's at least when I address the question. I really actually think it's a little bit related to what the families wants and what the caregivers want. So, have I had the conversation at 7? And yes, have I, I've had families consider doing it at that age. And have I also had pushback at an early definitive fusion at 9? So I think that has to be a part of it. I would say for me in general, it's been about an age of 8, recognizing that there's a pretty wide spectrum of what size a patient is. I think in terms of like pulmonary function, I think that's where I think we use data wrongly. That data in terms of thoracic height or thoracic length really relates to, idiopathic patients who are running around and have a very different level of function than our CP patients. And so it's hard for me to take that, those thresholds of 21 or 18 or whichever threshold you want to use and say, I'm going to apply it to this population. So I haven't necessarily done that, also because I think their underlying diagnosis is a much bigger factor than anything I'm going to do from a scoliosis perspective.
No, that's really great. Two more quick questions for you. One is the role of traction films, and specifically anesthetized traction films, if those are ever done at your institution.
I think it probably would add a little bit of improvement in terms of decreasing their spasticity and maybe getting a little bit more flexibility out of it. I do use traction films really universally for all of these patients, as opposed to any kind of benders. I also will assess them clinically. So, a lot of time, they're kind of laying on the exam bed, right? And then you're waiting kind of for them to relax and kind of gently pull on them. So a lot of it's also clinical. I haven't specifically brought anybody to the operating room to do a traction film though.
Okay, the last very quick question. Sitting x-rays versus supine x-rays. What's your take on that?
Yeah, so for me, sitting defines the indication of surgery, and supine and flexibility of the curve defines the timing of the surgery. Since patients are upright for a portion of their time, I think it matters in terms of the magnitude of their curve, but the timing of the surgery is driven by the supine flexibility films.
Outstanding, thank you. Okay, next we have Dr. Pat Cahill, who is a leader and innovator in pediatric deformity surgery. He's the Robert Campbell Professor at CHOP and University of Pennsylvania. So, Pat, would love to hear your thoughts on HRQL.
Great, thanks a lot, Amit. I'm excited to share this work because I think it's really the most impactful work I've been involved with in my career, and really honored that people like Paul Sponseller and Uni and Ryan have allowed me to be a part of it. So let's talk about the evidence surrounding what we do for kids with scoliosis and cerebral palsy. I don't think there's any debate that the radiographic outcomes are good, that kids start with a curved spine, they end with a straight spine or straighter spine, and that those outcomes are durable, that they maintain that correction for the most part long term. However, we have to balance that against the huge complication profile that our patients have. We know there's a big risk of medical complications, infections, prolonged hospitalizations, reoperations rates are very high as well. And so I think that that's a legitimate ethical question that Mo Diab and his colleagues asked in this letter to the editor of JBJS, saying, should we really be doing spine fusion surgeries and scoliosis surgery in patients with cerebral palsy, and called the field into question. And they asked for objective data and patient-centered outcomes, and suggested that the CP child be applied to answering some of those questions. And lo and behold, the Harm study group had already been pursuing that and conducting that study. And really, as Firoz laid out very nicely, the decision for the parents is, yes, my doctor says they think they can make my child's spine straighter, but what's really going to help my child live their best life? And so that's what HRQOL does for us. And so those of you that know Uni, please thank him, or next time you see him at a meeting, please thank him for his work in developing the CP child. This is anybody who's been involved with developing an outcome instrument knows that this is incredibly expensive and time consuming. It's an iterative process. It involves a lot of research professionals and psychologists and things like that. And really, he came up with a number of domains that answer the questions that are relevant to this population. So positioning and transfers, comfort and emotions, activities of daily living, so on. You can see the list here. And this is an extraordinarily well-validated and supported instrument that we now have in our field, that the Setting Scoliosis Straight used in a prospective manner to study the impact of spine fusion in cerebral palsy patients. And so it was a prospective study. It was controlled with non-operative patients, and the inclusion criteria were those patients that were in the surgical range and had a 2-year follow-up. And so what you can see here is that when compared, and we looked at these patients and how they were doing at 2 years after enrollment, whether they were 2 years post-op or 2 years after following them in the non-op group. And what we found is that across all domains, health-related quality of life improved. Every single one of these domains was statistically significantly improved in the surgical patients, particularly, and that change was improved when you compared the surgical patients to the non-operative patients. So if you look at the non-op patients, they stayed relatively the same. This change in 1.2 points is probably not clinically relevant, and it was not statistically significant. Whereas the operative group, this change was statistically significant, and it had a significantly large magnitude of change of 6.6 points, and we'll get into that. And so yeah, so the question is, how much of a change, or is 6 points really meaningful? There's no medically or minimally clinically important difference in CP child that hasn't been clearly established yet. However, when he was developing the questionnaire, Uni found that the retest only had a variability of about 2 points. So anything above that probably is a real change in a child's life. And when we compare it to other interventions, such as hip preservation surgery in this population, or baclofen studies, a lot of the baclofen pumps showed a difference. Some of them didn't, but we're sort of towards the bottom compared to some of the other interventions. Deep brain stimulation was very impactful for this population, but that in some ways makes sense. We're doing spine fusion surgery a lot of times as a prophylactic intervention to prevent further degradation and worsening in pulmonary implications of the disease. And so one of the real questions is, does the improvement from spine fusion surgery affect all kids to the same amount, or are there some populations that really see an improved benefit? And really what we found is that the size of the curve seemed to be correlated with the improvement in a health-related quality of life. So those patients that had progressed to a larger degree were the ones that saw the most benefit from surgery, and that makes sense. And so Burt just alluded to this. You can have the approach that I'm going to wait till this is a problem in a child's life, and then the surgery will have a profound impact in improving their life, or you can intervene at an earlier time point when the surgery is more of a prophylactic intervention. And the only thing I would say is that the change in Cobb angle seemed to be correlated with CP child score, so don't wait till the curve is too stiff, where you won't be able to get a significant correction with that deformity. So again, you can spin this either way you want. You can support your approach for intervening early when the curves are small, because they can end up still with a strong health-related quality of life, or you can wait till you are seeing impairments in health-related quality of life and then still be able to deliver a good long-term outcome in terms of health-related quality of life for your patients. So take-home messages. The patients without surgery seem to just kind of hold steady, whereas taken as a whole, patients that do have surgery improve, and this population is better than the patients that don't have surgery, and the kids with the biggest curves have the biggest bang for their buck in terms of improvement in health-related quality of life. And I want to thank all of my colleagues for the great work they're doing in this area.
Great talk, Pat. Very, very meaningful work. I think we have time for one question that came through the chat. What are your absolute contraindications? When do you say no, Pat, to patients?
Yeah, that's a great question. So it's I rely heavily on the whole healthcare team that's providing care for this kid. So if the anesthesiologists have some concern about the child, usually from a cardiac standpoint or a pulmonary standpoint, I think that's probably no. But other than that, what about you, Amr? Do you have a cutoff? I
agree. I mean, I must admit, I do say no from time to time, and factors much like you're stating, comorbidities that are just so high that the patient may not even tolerate being on their stomach, for that time. Like, that would definitely be one. And sometimes the bone quality is so poor, Pat, and the curve is so rigid, I feel there's not a whole lot that can be done in some of those patients.
That's a great question. Yeah.
Good. Pat, great job. We're going to move on to Dr. Paul Sponseller, who's made innumerable number of contributions in this space. He's been the PI for many of the studies that have been cited tonight. So Paul, tell us have we improved over the last decade?
Well, thank you, Amr, and especially thank you to Amit and both of you for setting up this well-organized and thoughtful webinar. And we have been doing this study for a long time. The harm study group is known for its AIS work, but we first recognized the challenges in CP scoliosis surgery and started a retrospective study in August of 2008. So that means we're just over the 15-year mark in looking at these patients. 15-year mark in looking at these patients. And we now have 852 operated patients and 150 non-op patients well validated with HRQOL scores as developed by Uni and just mentioned. So we wanted to look at the 15-year trends and operative characteristics, outcomes, and complications of patients undergoing this surgery. So we searched the database for all these patients and compared the outcomes and characteristics with a minimum of 2-year follow-up for the patients who we included. So that gave us something less than 850 patients. We had just over 600 patients, which is still the largest number to be thoroughly analyzed in any series out there. These patients were mostly GMFCS5 patients with curves in the mid 80-degree range and pelvic obliquities north of 20 degrees, which you'll know is clinically noticeable and is probably significant. So we found a number of trends over the years. In terms of the Cobb angle and the pelvic obliquity that we were tackling, the curves tended to be around 80 degrees or so and got better down to the mid-30s after surgery. The pelvic obliquities in the high 20s, and they were taken down to less than 10 on the average. And that didn't change too much over time. So we're seeing the same types of curves. We also looked at the type of pelvic fixation that we used, and it didn't matter what type of pelvic fixation was used mechanically. You can see that pelvic obliquity correction is well maintained with SAI screws and unit rods, but not quite so much with iliac screws, which are the white bars shown here. With the first two I mentioned, you get about 90% pelvic obliquity correction, and it hardly changes up to 5-year follow-up. In this study reported out by Sami Abu Samra about 5 years ago. But the iliac screw group doesn't correct quite as well, and it tends to creep up over time, slowly and steadily, to a rate of over 10% that have meaningful increase in the pelvic obliquity and often mechanical failures due to the connectors and to loosening of the screws. And here's a graph of these changes over time. We can see that the number of patients that have fusion to the pelvis has gone down ever so slightly, but we've done some good work showing that you should still fuse to the pelvis if the pre-op pelvic obliquity is more than 15 degrees. Unit rods have gone way down as shown in the line on blue, and the anterior approach is still being used about the same as it had been throughout, and there's some rare indications for doing it, as we've just discussed in some of the previous talks. Bleeding is a big thing that we pay attention to. Affects the safety of surgery and some of the ancillary complications. And it's been shown by an article by Jane et al. That neuromuscular scoliosis has the highest blood loss of any diagnostic category. But with AIS, Sherman's, and other genetic scoliosis, CP scoliosis has the highest blood loss. And this was, of course, a study done before antifibrinolytic use. And it was true even when normalized for the number of levels that the patient had fused. It wasn't just that there were long curves, if there was something intrinsic about the patient's thrombotic abilities. And Suken and others have shown that antifibrinolytics have decreased EBL by about 60%. And in fact, it was this compelling case that made antifibrinolytics first used in neuromuscular scoliosis when Fred Shapiro introduced for Duchenne's many years ago. And we are just starting to kind of consolidate on a right dose, which is about 30 per kilo loading and 10 per kilo per hour afterwards. And so what is the result of that? You can see this graph here from our 15-year study, showing that just after the study started, antifibrinolytic use started to take off in the blue line, showing the high vertical climb, and now it's nearly 100% used in these patients. And correspondingly, you can see a decrease in the EBL and also the number of red cells transfused. And all all three of those trends were statistically significant over time. So this has been, I think, a big and quantifiably noticeable thing that we've seen in our study. Hospital stay has gone down as well, but there's still long stays. The blue line is total hospital stay, and you can see that although it's gone down, it's not statistically significant, and it still is hovering over right around 10 days per patient on the average. Although ICU stay and duration of intubation have gone down, the latter being statistically significant, as indicated by the asterisk. Other complications have remarkably not shown much difference. Reoperation rate has not changed noticeably and statistically. VTE, pressure ulcers, and especially deep SSI has not gone down significantly over time. It still remains frustratingly high at 7% of this population. And knowing how disabling this complication is, we wish it would have gone down more, but it really has not statistically been driven down. Other wound complications also are about the same. GI complications and cardiopulmonary still shown here. So what about infection? We've shown that most of these are gram negatives or polymicrobial, and there are ways we've adopted as best practices to minimize the complication, including minimizing traffic, having an experienced team that works together often, and taking measures to reduce skin tension in terms of staging the surgery or using plastics to close, and also broad spectrum antibiotics either sprinkled in the wound or added to the bone graft, as Suken Shah has shown right at the beginning of the study in 2008. Wound management can include use of a drain, even if you're not a draining surgeon, use of an impervious dressing such as IVAC, and appropriate wound hygiene. And I like to aspirate the wound early on down to the deep layer if there's any question whatsoever. So here is the trend lines of all these complications. Reoperation kind of is showing here that hovering right around 5%. All wound complications together are shown here, not showing a manageable, noticeable decrease. And the SSI is the orange graph here, and it really has not gone down at all. Non-surgical complications, cardiopulmonary, GA, and so forth are shown here. As far as outcomes, Firoz has shown that the outcomes are actually improved compared to baseline and compared to non-op patients, and most notably in the categories of personal care, transfers and mobility, and overall quality of life. But comparing our improvements early on to now, these have not really shown noticeably measurable better changes than they were at the beginning of the study. So although we're making the patients better, we're not making them more better than we were before. So in conclusion, there have been some improvements in the process measures, such as decreased hospital stay, ICU stay, intubation, and blood loss, but no quantifiable improvements in the complications or HRQ overall, especially infection. And that leads us to conclude that some of the problems we face may be caused by factors that are intrinsic to CP, and new paradigms may be needed, including, of course, better judgment about surgical selection. And it's my personal feeling that the quality of the muscle envelope is a major factor in SSI. Whether the muscles are stiff, scarred, spastic, and tight seems to be a big factor in any patient, whether they will have a postoperative wound complication, especially at SSI. And that's why neuromuscular patients are so much at risk here. So I think it gives us, something to be proud of, but also I think a clear demonstration that there is no such thing as a never event, and we still have work to do in the future. So thank you for all of you contributing to this study, which we are well over 15 years into now.
Thank you, Dr. Sponseller. That was really an outstanding presentation. I just want to thank Dr. Sponseller for not only his compassionate and masterful care of thousands of children, but also for teaching many of us, including myself, on how to do spine surgery, and his incredible contributions to cerebral palsy and care of children with spinal deformity. So really, this man has, created a lot of the knowledge that we all rely on. So thank you, Dr. Sponseller. And in the last 1 minute, we have our very own Michelle Marks, who is the director of the Harm Study Group and the Setting Scoliosis Foundation, who's going to encourage all of you to participate in our CP research efforts. So Michelle?
Thank you. Thanks, Amit, and thank you, Dr. Sponseller and Dr. Samdani, for putting together this amazing webinar. So I'm honored to highlight the CP Scoliosis Registry and our associated research efforts in the Harm Study Group. So as Dr. Sponseller mentioned, the harm study group started as a AIS focused research with a comparison of anterior fusion compared to posterior fusion outcomes, but that morphed into a prospective multi-center longitudinal outcomes registry for AIS with some pretty landmark contributions. The data from that registry helps support the development of the SRS questionnaire and the Linky classification. But what it also built was an amazing infrastructure to support multi-center research. And so we really felt we could expand and grow in 2008. And we had a champion of Dr. Paul Sponseller step up to become the PI of our prospective study of CP scoliosis. And the study aims fed many of the talks that were given tonight. And it's really been the focus of our research is to focus on these topics. Dr. Sponseller has tirelessly, as he mentioned, for the last 15 years, driven this study forward, which has really evolved from a primary endpoint study to now a ongoing registry and is being expanded into selected neuromuscular scoliosis diagnosis such as SMA. Also, as Dr. Sponseller mentioned, we have nearly 1,000 patients enrolled and are being followed longitudinally. And this mid and long-term data that's coming through is going to be extremely valuable in understanding treatment outcomes in this medically fragile patient population. The HSG members have produced 33 peer-reviewed publications and 118 scientific presentations at annual meetings from our CP Scoliosis Registry. We're grateful for the support from our initial sponsor, CP Spines, and as Ed mentioned, now our sole sponsor from Stryker, so thank you. The data from our CP Scoliosis Registry has also enabled the production of our HSG textbook on neuromuscular spine deformity, which was published by TIMA and is still available. And this study has also led to an exciting collaboration that I'm happy to share about today. Hospitalist members of the impact group seen here, along with Keith Bachman, HSG member, are establishing a clinical best practice guideline for the perioperative care of surgically treated CP scoliosis patients. Following a deep dive on variations in care and a Delphi process, this best practice guideline is going to be developed and shared internationally. The data collected from our registry is truly improving care for patients with CP and scoliosis, but it would not be possible without our HSG site research coordinators, our central infrastructures, our surgeon members doing research in the evenings and on weekends, and all of the CP scoliosis patients and their family who agree to enroll in our study. We extend our sincere gratitude to all of you. Thank you.
Thank you, Michelle, and thank you for all you do to support the work done by the foundation, and thank you. And special thanks to Stryker. And then finally, just to conclude, just want to thank all the audience members for participating in this wonderful webinar. You can help further the mission by visiting the settingscoliosis.org website, texting scoliosis to this number, or contributing if you choose. So thank you again, everybody, and hope you have a wonderful evening. And thanks for working together to take care of this great population. And we'll end now.